So, thank you for including me in this ECMO India training course. And ECPR is a growing subject, and after the COVID pandemic, there is a big question: what will happen to those ECMO machines we have bought in hundreds in different hospitals? So probably the ECPR is going to increase, and we will use it for the mankind and for the biggest pandemic of the ever present, that is acute myocardial infarction and cardiogenic shock. So with that thing, we are starting this ECPR lecture, and obviously we don't have any conflict of interest or financial disclosure, but I'm very much interested in the awareness of ECMO. So what is ECPR? We know ECPR is emergency initiation of the ECMO during refractory cardiac arrest. And obviously the cannulation and the CPR goes simultaneously, and variety of settings can happen. ECPR can happen in emergency department, in the ITU, in cath lab, in the pre-hospital setting, which is out of hospital cardiac arrest most of the time. And it augments the end-organ perfusion and hemodynamics during that arrest. And after the ROSC, we continue to hear the ECMO. And many times the ECPR is done for the breach to decision, like in, you don't know why the patient got arrested, or patient came to your emergency in an arrested condition. You don't know the cause. It can be an MI, it can be a pulmonary embolism, it can be drug overdose, whatever it may be. So you will give patient, you resuscitate on
Dr. Arpan,
and then you
sorry to interrupt you. The slides are not moving.
You can't see the slides, sir?
Yes, slides are not changing.
I have not changed, just one slide I have changed.
Okay. Sorry. Yeah.
Okay, first.
So you can place it in the, good evening, Arpan. You can place it in the presentation mode. It's in the slide mode.
Yeah.
You can see enlarged version.
I don't think, are they changing, sir?
No, still you are in slide mode. It is not in the presentation mode.
Okay, I think I have changed it, but it is not getting transmitted. Let's see.
That's fine. Fair enough. Thanks.
Yes. Is it fine, sir?
Sir, yes, I think it's okay now.
That is fantastic. You have done it.
Yeah.
Okay.
Arpan.
Yeah. Thank you. So,
Thank you.
So it's changing probably. Okay, fine. So because I have explained this slide, so we many a times we do ECPR as breach to decision, whether we don't know what is the cause of the arrest, and after putting the patient on ECMO with CPR, we send the patient to cath lab or to the CT console, or for the toxicology screening, what is the cause of the ECMO. So with that idea, we know there is a patient selection for ECPR also. We try to maintain that, but many times it doesn't happen. So it is better to do ECPR when your age is less than 60, or you have a shockable rhythm, or you have chest compression within 10 minutes of arrest. Refractory arrest, more than 30 minutes, no ROSC despite standard ACLS, which is monitored ACLS or a good quality CPR. You try to know he doesn't have any major comorbidities, or you pretend there are some reversible cause like hypothermia, intoxication, or acute coronary syndrome. Now we have a chain of survival. We know it starts from the lay rescuers to emergency medicine medical system, and then emergency department to cath lab. So this is a chain of survival which is going. And obviously, if you keep calm and save the brain, that is the main way you have to do the ECPR. As we know, all the golden hour of ECPR is there. First 6 to 20 minutes, then 20 to 45 minutes, 45 to 60. So as you go down, your chance of survival goes down. And And AHA guidelines also tells us the CPR recommends the consideration of ECMO who have easily reversible event with an excellent ECPR, and contraindications which are followed all the contraindications of ECMO. And you have a futility of if you have unsuccessful CPR, no return of spontaneous circulation 5 to 30 minutes. So ECPR may be indicated. Here there is a red liner indicated on prolonged CPR in good perfusion or any mechanical support is documented. Now, the biggest question of ECPR is where we stuck everywhere. That is the how to cannulate the patient, how to enter the patient with the cannula. So, when the patient is in your ITU, had an arrest, it's a post-cardiac surgical ITU, it's an ECCU, you can open the chest and a surgeon is present, he can go for a central cannulation with a recent sternotomy or any peripheral cut down, he can go for the cannulation. Many a times it has happened in absence of surgeons where the regular ECMO physicians who are cannulating regularly, he can go for a percutaneous cannulations, even if access to the vessels exists prior to the cannulation. Many a times it happens inside the cath lab where two sheaths are present in your artery and the vein, and you just serially dilate them and start the ECMO. And percutaneous cannulation is usually performed if a patient is more than 15 kg, is at least big patients and is specialized in the cardiac cath lab, or you have some kind of imaging is there. And this is a classical picture when it came out in 2021 resuscitation with this, you need these things and C-arm, ECMO, echo, you have nurses and all the team work. It's ECPR is a teamwork. And what are the inclusion criteria? As you have a proper inclusion criteria, we have the ECMO team arrive and set up, including femoral and arterial venous access. You heparinize, you cannulate, you initiate the ECMO. You got an ROS, your ROSC, and you have seen that if aortic valve is opening adequately, you need not to vent the patient. You just continue the ECMO. And if you are not getting an aortic valve opening, then you go for an LV decompression. So these are the different steps it has been described. And the hypothermia, again, is a major indication which has been noticed in different parts of the world where temperature is low. Particularly, they have used very ECPR in this kind of hypothermic cardiac arrests, where a potassium level plays a very definitive role where to go for ECPR, or say if your potassium is less than 10, you can go for an ECPR. If it's more than 12, you are not allowed to go for ECPR because the outcome is very poor, or it has gone very far away from the recoverable time. So as we know, the cannulation techniques, it might be open for you need a surgeon to be present, semi-open, semi-Seldinger. Many times it's used. Or percutaneous. Most commonly we do the percutaneous thing where previously present cannulas, or during CPR you can put the cannulas at that point of time. In the picture we have seen this the way we do it in the patient. You can see that from the right side of the screen you have a guide wire which is going, which is the venous guide wire, and you have two sheaths which is present, which is in the same artery, same femoral artery. One is going towards the head and one is going towards the leg, and you just serially dilate the sheath which is going towards the head end, and you start the ECMO as soon as possible. And this is the way we do this to get the cannula in and you serially dilate. The way we do it, it should be a bit faster at that point of time. And this is a patient with admitted with us in massive pulmonary embolism. With a recurrent cardiac arrest, he had a failed thrombolysis. During the CPR, we have not been able to get some ROSC. Some ROSC came and again going, that kind of thing. So we take the patient on ECMO. And luckily we got this distal perfusion cannula at that point of time, and we could put the femoral and the femoral venous and the femoral arterial access at that point of time. And this is another case where there is a stuck mitral valve with cardiogenic shock. The patient presented in emergency. We did the CPR. For temporary time, he just came out of that ROSC. We shifted in the ITU. Again, he got arrested. By that time, we put a arterial line. and through that we could do this ECMO cannulation and put the patient on ECMO. So these are the conditions where many times it happens that the people with response with some amount of CPR and then coming and going thing happens, the rhythm and the pressures, where you will get some amount of lines. You should put that, you put a venous and arterial line, and later you can transfer it to an ECMO cannulation to start the ECMO. This is another one where peri-op MI happened in the left main disease. It happens arrested in the ITU. So with the CPR, we opened the chest and we cannulated the aorta and the right atrium, and we vented after that with the pulmonary artery vent. So this happens inside the ITU, and you can do the central cannulation after opening the chest. So these are the different cannulations I have shown that you can do during the ECPR scenarios. Obviously, surgical, there are problems with the surgical percutaneous in the mixed procedures. Somewhere bleeding is more, somewhere surgical presence is more, somewhere failure chance is more. So my take home is the ECPR thing should be done by a confident person who is doing regular cannulation, and the cannulation he is doing regularly on his own, that should be the prime method of cannulation at that point of time. A patient, a guy who is not regularly doing central cannulation, he should not attempt the central cannulation at that point of time. And who is the guy who is very much fine in doing central cannulation, very fast, a surgeon, he should not attempt a peripheral cannulation at that point of time, because the thing who is doing regularly at that point of time, he can perform better at the point of the stress. So that is the fine tuning of the cannulation we can tell. And the one thing we should remember that this is a mistake which happens very commonly during ECPR, because everybody is in hurry and it's a real emergency scenario. You need to connect the correct arterial and venous cannula. It has happened with different places, and it leads to catastrophe. So the arterial cannula should be connected to the arterial line, that return one, and the venous cannula should be connected with the drainage pipe. So that is most important. This is a very important thing. And as soon as you go on ECMO, you can cool the patient for at least 48 to 72 hours for therapeutic hypothermia, total body hypothermia, to protect the brain, and you can apply some ice over there. Neurological exam or other imaging may be done after some times following discontinuation of the neuromuscular blocking agent. And if you have a LA hypertension, that means your LV is getting distended, you have to take care of that at that point of time. And limb ischemia is a problem, because at that point of hurry, everybody wants to put the patient on ECMO first rather than taking the care of the limb. So if you get one or two punctures, within one or two punctures you are getting the distal perfusion cannula in fine, it is not, don't waste time on the distal perfusion cannula, because it is going to hamper your patient's outcome. So put one venous, one artery in the groin, leave for the distal perfusion. Don't attempt the distal perfusion at that point of time, because you have no pulse or you have a very thready pulse at that point of time. You can put it later on by your surgical colleague by opening the upper part of the femoral, or by this is the method where we have seen it works. So the same posterior artery you can open, and you can push that 5 French sheath and connect the main arterial circuit to perfuse the limb. So from here, you can only think that on that time where your perfusion to the patient is utmost important, you should use you should cannulate the patient first for the venous and the artery, and then only you should run the ECMO. Then go for the femoral, your distal perfusion cannula. And this is a picture where the progressive LV distension is there. This is a patient of our own patient where after ECPR we get that this kind of distension. You can hardly see he has a very poor pulse pressure, and your LV is getting distended, and your aortic valve is not opening. So this can happen. You have to think for the LV. You can go for the LV for the management of the LV distension in the form of, and this can happen. This is the ultimate picture when after LV distension, what happens? You can the patient can develop thrombus inside the under the aortic valve or at the level of the your LV. You can develop LV thrombus, so it can lead to catastrophe. So to avoid that, you can take early decision on your management of the LV decompression. Like most commonly what we use is doing the IABP, intra-aortic balloon pump. It gives some amount of pulsatility, it gives some amount of aortic valve opening so that the LV got some amount of decompression. That is the most common thing we do. But many times people have done, we have done also, we have created a large PFO as soon as the LA hypertension is high. If we, for the practically saying, this doesn't help as much as the IABP helped at that point of time. Or we have done, we have punctured the intra-atrial septum and drained the blood from the LA also and connected to the venous circuit even. So out of that, IABP gave the most commonest way of LV decompression. Now, the cerebral saturation monitoring is one of the important part because a femoral VA ECMO, as you are putting, is retrograde flow. So you have to give the adequacy of the cerebral saturation perfusion. When the heart is not pumping or it is not generating any native cardiac output, no pulsatility, you can give adequate flow which will go to the red vessel. So it has gone to the coronaries, it has given adequate flow, that's fine. But when the heart starts ejecting, then you have a problem. So then you have to need to monitor the cerebral perfusion, and you can see if the patient is getting awake, that's well and fine. If it is not, you can measure with the NIRS with the how is the brain is functioning. And this is a very landmark trial which came out in resuscitation, the CHEER trial, and with a very good survival of 55% by the Minnesota Resuscitation Consortium's advanced rapid reperfusion cardiac life support strategy. And they have given a 54% survival. This is another new study with the SAFE J2 study which happened in Japan. And they have an ECPR of almost 1,644 patients where a favorable neurological outcome at hospital discharge was 14.1%, which is very kind of low, but survival rate at the hospital discharge was 27.2%, and complication was observed during the ECPR is 32.7%. And if you add ECPR with the therapeutic hypothermia, that it's the more suitable strategy, they found it improving survival and neurological outcome than an ECPR with hypothermia. The traditional thinking the hypothermia will increase the bleeding, it has not contributed that so much. This is the data of April 2021, where you can see the adult ECPR survival compared by ELSO is 29%, with neonatal and pediatric is exactly 42%. And this is the April 2022, where adult has gone to 30%, and the rest of the thing is again the 42%. So, the ECPR results are in between around 25 to 30%. It is all over the world and is as per the ELSO registry. I just want to give, for the last thing, I just to share one case where if we found a 52-year-old male smoker with type 2 diabetes presented with acute inferior MI in another hospital, and they have attempted a primary angioplasty, but RCA origin could not be engaged. Meanwhile, he was become hypotensive and started on NORAD. His pH was 7.11 with cold peripheries, and got shifted to our hospital with the steep inotropes after 18 hours of MI, features of cardiogenic shock with acute kidney injury, sudden brady with hypotension, frank right ventricular infarct, still hypotensive, intubated, ventilated, NORAD, vasoadrenaline, all inotropes started, lactic acid started. So this is the usual thing, and you can see the right ventricle taps. If you measure, it comes around less than 6. And you can see the right ventricle, which is kind of swollen here. And the measurement of the TAPC, it's a flat kind of TAPC. You can see hardly any movement of the right ventricle. Now, with that thing, patient got arrested in the ITU, and we did some CPR and got some ROSC and put the patient on veno-arterial ECMO, and got a flow of 3.2 liters with 3,200 RPM. But there is a good, the NIRS in both legs we have put, we got a very different numbers. So because we could not put a cannula at that point of time, so distal perfusion, we put the distal perfusion cannula. And there are literature benefits where risk factors for critical limb ischemia in patients undergoing femoral cannula it has been seen that if the distal perfusion is necessary, so it has been told it's always better to put the distal perfusion cannula, because absence of distal limb perfusion is always an independent risk factor, particularly if you are doing at that point of ECPR. And the way we checking the distal perfusion, I've shared it many times, even in the social media also. We check the distal perfusion by changing the knob, changing the three-way with the perfusion, the distal perfusion flow, and we check a flat line of flow which is going through your same limb, which is given by the artery. It is not a pulsatile flow, but you should measure the mean pressure at that point of time, and it stops when you close the flow, and it reopens when you open the three-way. And this is the way we flow the check. Sometimes you get the pulses, peri-arterial flow gives you some amount of pulsatility or the balloon. And you can see after giving the distal perfusion cannula, you got a good both lower limb NIRS. And that adequacy of tissue perfusion, obviously, at that point of time is lactate and urine output. You might check the SCVO2 also. And target ACT is obviously 180 to 200 with ACT epididdy of 1.5 to 2 times. He improved on day 3. He started waking up, and we could had some amount of lung, wet lung with the desaturation, and started throwing a deoxygenated blood from his native cardiac output. We get a harlequin kind of thing. We increase the FiO2 of the ventilator, and we just manage that thing by increasing the ventilator FiO2. And there is an harlequin. We did a CT angio because we could not engage the catheter at that point of time in another hospital. We started doing CT angio where we could demonstrate there is a you can see the harlequin phenomena. This flow is from the femorals, which is going up to the arch, and the rest of the flow here, it is coming from the native artery. So there is a big harlequin mix at that point of time at the level of the your aortic arch. So harlequin is demonstrated over here by your CT angiogram, CT aortogram. And day 6, with the touch of milrinone and NORAD, we started improving with that kind of LV and that kind of RV. And obviously, as you know, how we come out, there is a chapter on weaning also. We come out when the hepatic function improves. And if there is no improvement in the renal function, we continue to give CRRT or the slate, but we give some time for the hepatic function to improve. And at least the mean 72 hours should be given this kind of patients if you want to come out. So compatible for myocardial recovery, MAP more than 60, if you have a pulsatile arterial waveform, lactate less than 2, PO to FIT ratio less than more than 200. These are the prerequisites. And for the echo, you see the LVEF is growing more than 20%, VTI is more than 12, and TAPC more than 12. Here, as the right ventricular dysfunction was there, the previous TAPC, we measured around 6. This time it was more than 12, so we started coming off. We put a bridge. Bridge is a connection between the venous and the arterial line before weaning the veno-arterial. Many times people don't use bridge now, but many times we put a bridge. And as the weaning characteristics goes on, one person see the echo, and one person comes down on the flow. We see, we serially check the aortic VTI, the ejection fraction, the eyeballing of the LV, and the TAPC, which is also important. and you come down by 0.5 liter per minute over a period of 10 to 15 minutes. Many times you come down by half an hour. You go slowly and regular with the regular checking of the aortic VTI. Patient, there should not be any fall in the pressure by 40 or a sudden rise in CVP. Then you have to abandon the procedure of weaning and go back to the same flow, full flow, and don't give any weaning challenge for next 48 hours. The mistake we do, we give weaning challenge today. Okay, it has failed today. We give tomorrow. It doesn't work. Or today it failed. We'll give in the evening. It doesn't happen. Once weaning is abandoned, you have to give at least 36 to 48 hours time. Your heart is not ready for the weaning again before that. You have to keep in mind. And you have to keep in mind that percentage of patients of this kind of shock coming out varies in different centers with different causes. It is 30 to 70% almost. And out of that, 20 to 65%, they come out of ECMO, but they don't go home because they die, they lost because of the multi-organ failure. So this you have to explain to their family members. And decannulation, as we do surgically, the femoral arterial cannula and venous cannula, we can take out percutaneous. And if you have a significant pulmonary dysfunction, like our patient had for some 2 days, we might change from VA ECMO to VV ECMO for shorter period of time at that point of time. Rehab and follow-up is most important that we do. We continue to do for our survivors. So thank you. Spread awareness for the doctors and the common people with this, and follow them up till they are your Facebook friends. Thank you. And with the take-home message, obviously for the ECPR, the starting after 20 minutes of CPR is the ideal time. Goal is to do 60 minutes after cardiac arrest. You can prolong it if your patient is alive, you can see the signs of life or neural protection is adequate, you have good quality of CPR. Selected patient will give you good result. Mixed or percutaneous, the last point I told is what you do best, you do at that point of time, because you are the best judge what you can do at that point of time. Pre-hospital CPRs, though we have not started yet the OHCA practice in our hospital. I don't know, I have no much of experience at OHCA, but IHCA, the in-hospital cardiac arrest, we have done a good amount of ECPRs. OHCA, we have not performed. This program needs to come out in the future. Thank you.
Thank you, Dr. Arpan. Now, if Dr. Madan is getting late, then he can proceed with the lecture, or Arpan may continue with the second lecture. What is the option?
Should I continue, sir?
Dr. Madan?
Sir, can you repeat you're talking about, please, sir? Vivek here.
You want to take the lecture, or I ask Dr. Arpan to finish?
Yes, sir, I can take this.